Thank you for joining us for this TAD talk with our keynote speaker, Dr. Catriona Steele. My name is Ed Steele. I'm president of the National Foundation of Swallowing Disorders, and I'm also a long-term head and neck cancer survivor. My treatment included a salvage surgery and the severing of my left limbal nerve, which has resulted in severe dysphagia, which was diagnosed in 2007 and left me with a speech impediment. As most of you know, the Foundation's mission is to help all those with a swallowing disorder. And we do that through four pillars: providing patient support, raising dysphagia awareness, funding promising research, and providing swallowing disorder education, such as this talk this evening. And I'd like to give an example of one of the pillars. And tonight, the example I'd like to share is that our website receives more than 30,000 web page views per month. And our most popular page is our dysphagia exercise page at about 6,000 views per month. So if you're not familiar with it, you can get to it through our website under resources, or you can Google dysphagia exercises, and you'll find us on page 1 of the search results. It's a great resource for therapists and patients. It includes 14 exercises with videos and a template that a therapist can provide to their patient. And that template is in English and Spanish. A few quick housekeeping items. You will be muted during the presentation. We encourage you to type questions into the question box at any time. This will be recorded and available for free. That takes us about a week, and there are no ASHA CEUs provided for this talk this evening. Catriona Steele is a clinician scientist working in swallowing and swallowing disorders. She has a background as a medical speech-language pathologist and is director of the Swallowing Rehabilitation Research Laboratory at the Kite Research Institute, the research arm of the Toronto Rehabilitation Institute, the University Health Network. Dr. Steele is also a professor in the Department of Speech-Language Pathology, Rehabilitation Sciences Institute, Camerty Faculty of Medicine at the University of Toronto. She also teaches in the Masters of Orthology program at the Catholic University in Belgium. Professor Steele holds research funding from NIH and several industry partners. To me, she is the Pablo Picasso, meaning very prolific of publishing and speaking in our field, with more than 185 published peer-reviewed manuscripts, the delivery of more than 290 abstracts, and 280 invited presentations around the world. She is an associate editor for the Dysphagia Journal and a member of the editorial board for the Journal of Texture Studies. She is also a founding and current member of the board of directors for the International Dysphagia Diet Standardization Initiative. And we'll be putting a link to that and information about her lab in the chat box. Catriona is currently the Secretary Treasurer of the Dysphagia Research Society and will serve as the DRS President in 2024. We are so grateful and honored that she has generously volunteered her time today to share her knowledge. And with that, I will turn this over to Catriona, but I would also like to thank Elizabeth Lipton-Daly for all the work she did in organizing this. So with that, Catriona, I turn this over to you. Thank you.
Thank you, Ed. Everybody can hear me okay?
Yep,
well, it's super. It's really a pleasure to be with you all this evening. And I'd like to thank Elizabeth and Ed for the invitation to speak with you tonight. And I hope we'll have time for some discussion at the end. I was asked to speak about thickening liquids and texture modification, which is obviously a very popular topic at the moment and a controversial topic. So I hope that we will have time to discuss some of the controversy as well. We will later in the slide presentation get to two polls where I'm hoping we'll be able to generate some word clouds. And I put these links in the chat. And between now and when we get there, if you would take the time to go to those links and enter your answers to the questions, that hopefully will work, and we'll get to get a sense of the audience opinion on these two questions. So as Ed kindly mentioned, I'm located in Toronto, up in Canada, and my research lab is located at the Kite Research Institute, which is part of the Toronto Rehabilitation Institute at the University Health Network, which is our largest academic teaching hospital. And I've been at this location since I graduated with my PhD. And I want to take just a moment to acknowledge the members of my lab. This is a picture of the people who were in my lab last year. And we're currently bringing some new people on board, but none of this work happens without the tireless and loyal contribution of these people. And as Ed also mentioned, I do have a number of disclosures as shown on this slide. And in particular, I want to point out here my affiliation with IDSE, the International Dysphagia Diet Standardization Initiative, which of course is a relevant disclosure for the topic that we're discussing tonight. So before we get into the slides, Elizabeth is going to help me administer a couple of polls through the polling function in this meeting software. And so I'd like to find out a little bit about who you are as audience. We've got 260 people on at the moment. Elizabeth, could you run the first those 3 questions?
Yes, we just launched the "Where are you located" one.
Okay. So I'm assuming we've got primarily a North American audience this evening. Is that how it's playing out?
Yes, so far 86% are from North America, and we have about 80% of the people on the call who have already voted. Give them a few more seconds here and I'll close it. All right, and then I'll share the results here. So hopefully you can see on your screen, it says 85% are from North America. We have 11% joining from Australia or New Zealand, and then 2% joining from Asia or Africa. And I apologize that we had to group those 2 together. GoToWebinar only allows for 5 multiple choice options for that.
Okay, and maybe we can move on to the second question, which is about people's professional background or their experience with dysphagia.
All right, so I've launched that one here. So far, the majority are speech pathologists. I'll give people a few more seconds here to vote in the poll. All right, and I'll close the poll here and share the results. So we have about 90% on the call who are speech pathologists, 5% are in another healthcare field, 3% are family members or caregivers of somebody with dysphagia, and then 1% is somebody with dysphagia.
Okay, great. And then the final poll is about familiarity with IDSE. So maybe we can run that one.
Yes, I launched that one here. I'll give everybody a few more seconds here to vote. All right, I'll close the poll here and share the results. So we have about 50% of people who have heard of IDSE but don't regularly use the testing methods. And then 41% say that they are very familiar with IDSE and regularly use the testing methods. And then about 10% say they've never heard of IDSE.
Okay, excellent. So we've got a range and that will set us up well for our discussion. So I'm going to move on then on my slides and move my camera window out of the way. All right. So what I'd like to discuss with you this evening, I'm hoping to cover these 4 major themes. First of all, why do we use texture modification in dysphagia management? Secondly, to discuss terminology and methods and resources that are available for us in measuring texture and classifying it. Then I'd like to cover what I consider best practice principles in the recommendation and use of texture modification. And then the final topic I'd like to cover is one that usually doesn't get a lot of attention. And I'd like to spend a little bit of time discussing food texture specifically and its relationship to choking risk, which I think is a topic where we have lots of room to develop as a field to develop better practice. So let's start with why we use texture modification in dysphagia management. And this is really an idea that's been with us as a field since the very beginning, at least the beginning in terms of our publication history. So if you go back to the very first year of the Dysphagia Journal in 1987, in the third issue that year, we saw a focus on texture modification. And particularly the editorial introduction to that issue of the journal speaks about this being something that is available to us to help manage dysphagia, and coins the term feeding competence, which I don't think we use very much these days, but defines it in terms of the ability to ingest foods of various different consistencies or various physical characteristics. And on the right-hand side of the slide, you can see the major article in that issue about rheology, or the flow of liquids, and what is called the swallow safe bolus. And so I think that this is a really interesting concept. What is a swallow safe bolus? And we do tend to use the word safety when we're talking about issues with swallowing. And these particular authors talk about competence in swallowing being something that depends on the physical characteristics of food and drink, and whether or not the person is able to take that food and drink and through the process of oral handling of the bolus to turn it into something that is safe to swallow. And so this is where I'd like to try and do a detour out to that first word cloud exercise, because I'm interested to understand what words come to your mind when you read the term swallowing safety or safe swallowing. I'm going to try to exit my slides for a moment and see if I can see that word cloud coming together. So yes, so here, I don't know if you're able to see it, but I'm seeing the word aspiration being very prominent, airway protection, nutrition and hydration. There's a comment that I saw about this not being the right concept. I see the words reduced risk, and hopefully you're seeing a lot of these words coming up on the screen. We also see choking as a word that's larger in this word cloud and getting more votes. So I think that's great. We're also seeing other concepts like quality of life, comfort, risk management, weight loss, and caution coming up. So let me go back to my slides and pick this up. Thank you for your participation on that. So this article by Koester and Schwartz way back in the beginning of our journal was a review article, and they said that it was about the physical aspects of a bolus that are pertinent to its unimpeded passage through the oropharynx, the food pathway, without three things that they would presumably characterize as risks regarding safety. And those three things were aspiration, or entry of material into the airway, choking, or retention of material in the pharynx. And so a bolus that doesn't lead to those three things, by their definition, was what they would call swallow safe. And so this word safe appears right at the very beginning of our literature, and I'll acknowledge right now that it may not be a great word here, but it is generally a word that we associate with the issue of material entering the airway. So the retention of food in the pharynx these days often goes under the heading of efficiency as opposed to safety. And here I have a still shot from a video fluoroscopy that sort of illustrates these two major functional concerns, one of the ability to protect the airway from penetration and aspiration, and the second being the ability to clear material efficiently through the pharynx without leaving residue behind. So this word safety is a pretty loaded word, and I think what's important to think about is what's the opposite of safety? Is it risk? And that tends to be how we phrase our concerns, that they involve risk. And I think it's important for clinicians to be very careful when talking about the kinds of risk that might come with a swallowing impairment. And I like to think of these as direct risks and less direct or indirect risks. And so the direct risks that we should be concerned about are indeed the risk of material entering the airway, which we do believe can have downstream consequences. Then there's the risk of choking or actual airway obstruction. And then thirdly, the risk of bolus clearance. And these for me are direct risks in the sense that we should have tools available to us as clinicians to mitigate these three risks. But what about the downstream risks? And I think it's important for us to recognize here that these other conditions that we sometimes invoke when we're speaking about the risks that we're concerned about with patients are less direct. So obviously the concern about pneumonia and respiratory infection is something that aspiration may play a role in. And dysphagia may also contribute to risk for malnutrition and dehydration. But there are all sorts of other things that play into these risks. Maybe they are sufficient without dysphagia being part of the picture, or dysphagia plus these other risks can add up, other conditions can add up to these risks. So it's not as simple as aspiration being something that can lead directly to pneumonia. And in fact, when it comes to pneumonia risk, what we understand is that there's sort of a triple threat scenario. The first being that we have to have bacteria in the vicinity of the oropharynx, and that those bacteria have to be respiratory pathogens that could cause damage and lead to an infection if aspirated. Secondly, those bacteria have to get into the respiratory system, and this is where aspiration as a phenomenon serves as the vehicle or the mechanism for transporting those pathogenic bacteria into the respiratory system. And thirdly, we now understand that both of those other two things can exist, and a person may be able to do just fine until the third part of the equation comes into play, being an impaired immune response. And so it's not as simple as saying, I know that there's aspiration occurring, therefore there's a risk of pneumonia. We have to take these other things into consideration. And so as a field, we need to be careful about measuring our effectiveness for these indirect consequences. And I think we should be focusing in terms of our direct effectiveness on the things that we can directly mitigate. So this then brings us to issues of texture modification and the terminology and resources that we have available. And if you do go back in the literature, this article in 1990 is really the first one that I've been able to find that outlines the idea of designing diet in a way that items that are more likely to be aspirated are omitted from the diet or excluded, and items that are less likely to be aspirated are included. And this was really how we operated for a long time. It's a really quite interesting article to read. It's not a research article per se, it's more description of the diet system that was developed in the Veterans Affairs Hospital where Dr. Michael Grower was working. And you can see here that they included 3 levels of thickened liquid within that diet system. And these should sound familiar. So the first degree of thickening they called nectar consistency, then the second degree honey consistency, and the third was labeled pudding consistency. And then they have quite an interesting discussion in this article of the choices they made about what would be allowed or excluded from the aspiration risk reduction diet. And you can see that they focused on avoiding things that they thought were more likely to cause trouble if they entered the airway. So we've got avoiding pieces of food that break easily into small pieces. We've got avoiding large chunks like meat in stew. We've got mention here of sticky foods, such as white bread being something that they avoided, and also peanut butter. And so we're starting to see here concerns not only about penetration aspiration, but also about bolus clearance, all wrapped up under the heading of aspiration risk reduction. And this really became the system that was in wide use as we entered the 21st century. And you can see here the document, the National Dysphagia Diet, which was published in 2002 and really entrenched that approach as the model in North America. You can see here that within that National Dysphagia Diet, there were those 4 levels of liquid from thin through to pudding thick. And then there were also 4 diets per se, which spoke to the food characteristics that were allowed on these diets. And they used the terminology pureed, mechanically altered, and that sometimes was called mechanical soft. Then there was a chopped level and then regular food. Now, around that time, there were a lot of discussions about whether we could standardize terminology for diets, not only within countries, but also internationally. And so this slide is a table from an article that the IDSI group published around 2013, 2014, where we surveyed the terminology that was in use in various countries around the world. And what becomes obvious is that there were different terms used, different methods. So you can see under the United States line at the top, in addition to the labels, there were numeric measurements of viscosity in centipoise that were proposed. You can see in other places they used color schemes for these different levels. You can see that the number of levels differed across countries, and so there was quite a lot of variation, and with that came, we felt, the potential for confusion. This is the liquid table, and then this is the comparable food table. One of the things I like to point out about this food table, if you look at the English system on the second line, the United Kingdom, they use the letters of the alphabet to code their different levels. And you can see that the most modified food in blue was texture E. So the regular diet would have been texture A, and then it went from A to E. But if you jump down just 2 lines to Ireland, they also used letters of the alphabet, but in the completely opposite direction to England. And so again, a lot of potential for confusion. And this was really one of the major inspirations behind the formation of the International Dysphagia Diet Standardization Initiative, or IDSI. And in 2017, we published the first version of the IDSI framework, shown here, and it was then updated in 2019. So if you're not familiar with this, this is a continuum of consistency terminologies both for drinks and for foods. And one of the breakthrough moments in developing the framework was the realization that as liquids become thicker, they actually cross over and have the same characteristics as modified foods. So if you think of soup is a good example where from a consistency perspective, a soup might be very thin and a liquid, but it's actually considered nutritionally to be a food. And so where do we put that on the framework? In the framework's answer to that would be we would need to measure the consistency of that item to know where it falls on the framework. Applesauce is an example that's considered a pureed food, but it actually would have very similar characteristics to an extremely thick liquid. And so one of the things about the ITSE framework is that in addition to agreeing on these, the number of levels on the framework and the terminology, we wanted to move away from the historical perspective of allowing some foods and excluding others, so that we no longer would support the idea of saying this diet can contain these foods but not these foods. Rather, we feel that it's better to describe the characteristics of food that you think are suitable, and then people can go out and measure the properties of food available to them. They may need to modify those properties, but it's the characteristics rather than the food itself that are defined in a diet recommendation. And to support people to characterize those foods and liquids, ITSE came up with some testing methods that are valid but intentionally simple in that they could be performed by everyone. And really the goal here is to empower clinicians, people with dysphagia, their family members, food service staff in kitchens, nursing staff, to run these tests at the point of delivery of food and liquid to be confident that they know which level that item falls into. And so if there seems to be a problem on a given day, perhaps running the test would help you to understand that maybe something is unusually thin today or unusually thick today, and therefore it might not be suitable for a particular patient given their texture modification needs. So the flow test is used for characterizing the flow properties or thickness of liquids from level 0, which is regular or thin liquids, up to level 3, which is moderately thick liquids. At that point on the continuum, liquids stop flowing, and so we have to move over to using the food characterization tests, which involve things like compressing the food with a fork, seeing whether it will drip through the holes between the prongs of a fork, and looking at the size of the particles in the food if there are particles. And I'll get to more of that in a moment. The flow test was originally described to use a standard slip-tip syringe shown there in the second figure on the slide. You fill it to 10 milliliters. You then allow the liquid to flow out the bottom of the syringe for 10 seconds, and you stop the flow and see how much material is left, and that decides which level on the framework that liquid is. We have recently moved to making a funnel available as a measurement tool because the particular syringe needed for the test is not available everywhere internationally. And so there are now funnels available. The distribution is in process, but you should watch for that. The syringe is still valid, and if you can get that, we recommend that you do so, but the funnels are coming. And this video shows you, it's going to show 4 syringes with 4 different liquids flowing through the syringe, and you'll appreciate the different amounts of liquid that are left behind in the syringe after 10 seconds. So you can see on the far left, we've got the least amount, about 2 milliliters there. That would be a level 1 slightly thick liquid. And on the far right, really nothing dripped out of that syringe, and so it's still at 10. I'll just play it one more time so you can appreciate that. Oh, I'll try. All right, so those are methods available to help classify texture. In terms of how we should be using texture modification, I think it's very important to remember that the goal here is to facilitate safe and efficient swallowing, that is, swallowing that minimizes penetration aspiration and also optimizes bolus clearance without leaving residue in the pharynx. And the use of modified textures here is compensatory primarily. That is, if somebody's having difficulty on a particular texture, then by altering the texture, we can manipulate those 2 concerns of safety and efficiency. However, we've learned over the years that texture modification could also, in some people, have a rehabilitative or maintenance purpose. And so there are some paradigms where people are working with deliberately challenging consistencies to try to rehabilitate swallowing function across a variety of textures. Or in the opposite direction, if somebody is experiencing degenerative or deterioration in their swallowing function, then texture can be used to try to maintain function and to guide stepwise, hopefully small changes in diet texture variety that's in a person's daily menu. I think that texture modification was always intended to be an intervention of last resort, but unfortunately it has become an intervention that we go to very quickly and very easily. And really we should be trying to remember that we should be trying to help maintain the widest possible variety of food texture and liquid consistency in people's diets, primarily for purposes of maintaining their ability to enjoy food and liquid, but also for maintaining their function in the broadest sense. One of the things that I think is very important is that the recommendation for a modified texture should be something that is based on assessment. That is, you shouldn't assume that you can determine which textures are going to work better for a patient. And indeed, we've learned probably more about how texture modification can be unhelpful or contraindicated over the years, such that we now understand that there can be a trade-off, that if you are thickening liquids for the purpose of minimizing penetration and aspiration and promoting safety, at some point those liquids can become thick enough that they tend to promote residue in the pharynx. And so there's a safety efficiency trade-off, and we need to be very careful about that. And I think we need to be very careful about not being overly conservative or restrictive. And I think the fact that people have learned that we tend to recommend altered textures has led to overuse of modified texture without adequate assessment, and certainly without adequate reevaluation. And of course, we always should be working with the patient and their family to understand their choices and preferences and see what we can do to enable them to consume the most unaltered diet possible, whether that might involve other maneuvers or to optimize their swallowing function. So I'd like to just transition over to the issue of food texture modification and choking risk, because this is, for me, an area where I think we still tend to make assessment recommendations without adequate assessment, and well-intended recommendations, but without really having valid methods for determining which are the optimal textures. And this slide captures the dilemma that is faced with respect to food texture, where I would say one of the most common exceptions that we see on diet texture recommendations is for perhaps a pureed diet or a minced diet, but we're going to allow bread. And this really illustrates the quality of life dilemma that comes with texture modification of food and our lack of good tests for knowing what we can recommend. And so at this point, I'd like to pop out to the other Slido question and ask you for words or issues that you consider if you are a clinician when you are determining a food texture recommendation for a patient. And if you're a patient or a family member, what do you think people are considering in this context? And I will just pop out to that Slido. So here, not seeing a word cloud at the moment, but lots of words coming up. Quality of life, oral function, patient preference, least restrictive, medical status, stage of life. A lot of comments about patient preference, willingness to change. And so I think those are all really important concepts. Also lower down in the list here, seeing mention of teeth and dentition, oral strength and function. And so this is what I was expecting to see in terms of the range of things that people are considering. I'll just go back to the slides. All right, so in terms of the IDSI framework, we identified 5 levels of food texture, from regular at the top, level 7, down to liquidized at level 3. And originally, we did not have the easy to chew subgroup in the regular level. And you can see that there are the 3 intermediate categories are soft and bite-sized food, minced and moist food, and pureed consistency. And there are really 3 key properties of food that are manipulated across these different degrees of texture modification. The first of those is particle size. So when you look at the food, what size are the pieces? And here we specified upper limits for the particles that are in the food for the different levels. And so at level 4, there should be really no particles. It should be a smooth puree. At level 5, we set upper limits of 4 millimeter sized lumps for adults and half of that for children. And then at level 6, we set an upper limit of sorry, that should be 1.5 centimeters, so 15 millimeters. So they get larger as we go up. And what we're manipulating here is the degree to which the person is able to break food down themselves with their oral function into pieces that are small enough that they are unlikely to be a choking risk. The second property that's manipulated is the hardness of the food, or the degree to which it breaks. And so we have a test of hardness there. And then the third property is stickiness or cohesiveness, so the degree to which the food holds together. And I want to share a story with you to illustrate how important food texture specification is. So let's name this patient Esther, and she lives in a long-term care nursing home facility, and she's been to the hospital for a cardiac test, and she is waiting for her ride back to her residence. And she had to fast before her test, and so several hours have passed and she's hungry, and she asks the attendant whether she could have some food. And so they looked at her chart, and they saw that at the residence where she lives, she's on a diet that is described as regular, pureed, regular. And so they interpret that, and they provide her with an egg salad sandwich. And so here we have 2 pieces of bread on either side of a filling that might be considered to be in the domain of pureed food by some people. There's also some lettuce in this sandwich, and so we've got a complex consistency here. And the question is whether or not the label, regular, pureed, regular, should or shouldn't have included this particular diet item. And of course, the answer is that it shouldn't have done, and that people didn't know how to interpret that diet recommendation. The regular here applies to the nutritional specification of the diet. So is it high salt, low salt, diabetic, those kinds of considerations. The pureed should be referring to the food texture, and the regular on the third terminology should be referring to the liquid consistency that is suitable for this patient. This is actually a real story that happened here in Canada, and the patient was given an egg salad sandwich to eat while she waited for her ride home. And unfortunately, she choked and died on that egg salad sandwich. And choking is actually the second highest cause of preventable death in facilities providing long-term care for elderly people. There's been a study in Australia that points this out as one of the most preventable causes of death. And if you look at the literature, it's not so straightforward to understand which kinds of consistencies lead to choking episodes and, unfortunately, to death. You can see here a long list of foods that have been implicated in choking deaths on autopsy. So these do include meats, particularly meats that may have large chunks, but also vegetables, fruits. Here, people are concerned about things like seeds and skin. But you can also see a group here of foods that arguably should be in the pureed domain that we don't usually think of as being a choking risk, things like porridge or mashed banana. And then as you go down the list, things that might not surprise you. Bread is actually one of the most commonly implicated foods in choking deaths. There's also, if you look at the literature, an alarming increase in choking deaths around special festivals and occasions like birthday parties. And in Japan in particular, this picture is taken from a visit I made to a nursing home in Japan when I was there the last time. And it happened to be birthday party day in this nursing home. And these were the plates of mochi that were being offered as a birthday party treat in the nursing home. And mochi is a sticky rice cake that's particularly enjoyed around the Christmas, New Year season. And if you look at Japanese autopsy literature, there's a very marked increase in choking deaths immediately after those holidays. I want to share with you just a quick video to illustrate the importance of particle size in choking risk. And this is a video shared with me by my colleague, Joe Murray, and Joe is very good at doing endoscopy on himself. And in this video, he is illustrating the airway risk associated with food particles in the vicinity of that 1.5 centimeter range. So here, sorry, I moved too fast. So here he's showing a piece of fruit cocktail that is less than the 1.5 centimeter upper limit. And you're going to see relative to his larynx, his airway, how big that piece of food looks. He's very good at controlling where it goes. And I think you can probably have a sense here of some risk associated with the possibility of that food going into his larynx. And then he swallows and that one disappears. And this comparison video, it's just slightly larger, this piece of peach, and he's going to show you how that compares to his airway. He's actually deliberately, under endoscopic guidance, allowing that food to go over his epiglottis towards his larynx. And it's not difficult for us to imagine that if that were happening, how easily we could end up in an emergency situation of airway obstruction. So what do clinicians tend to do to evaluate choking risk? Well, what's interesting here is that we tend to use the same methods that we use for evaluating liquids when it comes to foods. We don't have a standard inventory of foods to evaluate. Some people will look at video fluoroscopy, and here we don't have standard barium products for this range of levels on the IDSI framework. And in fact, video fluoroscopy is probably not the ideal test for exploring food texture. And if you think back to that video, endoscopy might be a more informative procedure. And some clinicians will go as far as measuring chewing using some standard tools like the test of mastication and swallowing of solids, where we look at the number of chews and the duration of chewing for some standard foods, standard crackers in that test. But none of these tests actually really address the issue of choking risk because none of them look at the properties of the bolus at the point when it's sent into the pharynx. So we've just recently published a paper proposing that what we really need to do here is develop a test that does just that and looks at the degree to which food oral processing alters foods to make them a suitable consistency. And our idea here was to have people expectorate a bolus at the point of being ready to swallow, and to use IDSI's testing methods to characterize that processed bolus and to see whether the foods were at level 5 or level 6 on the framework. We used 3 different foods, as you can see here. The Carr's table water cracker is the food used in the Thomas. And we had people chew until ready to swallow, then expectorate the bolus, and we characterized it with IDSI's tests. This is just one example of the variety of sort of processed boluses that we found with the carrots. These are in healthy younger people, and you can see quite a variety of food consistency here. And we found that the carrot, there was a range right from level 4 up to level 6 in those boluses, and similarly for the carrot cracker. And the particular gummy candy that we had chosen proved to be much harder to process and not a good stimulus for testing oral processing. So this is an early suggestion of hopefully a standard method to be developed for evaluating the effectiveness of oral processing with a view to developing a test of choking risk. So with that, I'm going to stop, and hopefully we'll have some time here for questions.
Dr.
Elizabeth,
Steele,
are you going to moderate this part?
yes, I am happy to, if that's okay. The first question I see here.
Sharing my slides.
Excellent. Somebody is asking where they can get the new IDSI funnels.
Yes, so at the moment, the answer on where to get the funnels is that some of the manufacturing companies like Simply Thick and Nestle and Hormel, who are IDSI sponsors, have early versions of the funnel available for distribution. And we're currently working on developing a process for ordering funnels. So it's a little bit early, but it's coming.
Excellent, thank you. Another question here from somebody asking about why there's not more research or talk about weight loss and nutrition in people with dysphagia. Or perhaps where to find this information and learn more.
Yeah. So I would say that in Europe, there has been more of a focus on malnutrition as an outcome related to dysphagia than there has been in North America. There is some information in North America. I think it depends on the caseload where you're looking. So we do know, for example, that in long-term care facilities where texture modification is widely used, that in fact, one of the downsides of using pureed or minced foods is in fact weight loss. And that happens for a variety of reasons, partly because the nutrient profile of the food is altered during the modification process, but probably also due to reduced intake.
Excellent, thank you. I want to read a comment here from one of the SLPs on the call. I appreciate their honesty, and maybe perhaps you can talk about ways to advocate. But the comment is, I'm sad to say that I often adjust a patient's diet to suit the level of care that they will be getting. For example, if I know the staff will not take the time or care to feed them, then I simplify the diet to make it easier for the patient.
Yes, thank you for that honesty. I think this is a very real and pragmatic decision that we have to work with. And I think that the comment reflects an awareness of the fact that speed might be a consideration. And I remember back very early in my career being very concerned about this and just how long it would take to give people the attention and time needed to consume a meal without over modification. So I think that continues to be a risk. I hope there will be advocacy. I think it is an important point, and I think the first place to start, in fact, would be to highlight what is known about the risks of over-modifying from a nutritional perspective, but also from a quality of life perspective. It's a tough one, and I'm thinking out loud here, you know, with COVID, we have even tighter resources on staff. So I think this is continues to be a challenge.
Thanks. I agree. Another question, a couple questions actually about pediatrics and wondering if IDSI applies in the same way to children and infants.
Yes, so thank you for that. So yes, the IDSI framework is intended to apply across the age span and indeed across cultural boundaries and geographical boundaries. When we have listed things like particle size, there are different recommendations for children than for adults because their systems are smaller. And indeed, some of the, the slightly thick liquid level was something that was already in use with babies with dysphagia, but not really recognized. And so it now has its own place on the framework. And I think, in fact, some of the feedback we've had is that by enabling parents to learn to do the testing, it's really been empowering to moms to be able to problem solve difficulties that they see their babies having. So for example, formula might thicken up as it cools down, and appreciating that with the flow test can help somebody problem solve whether they heat up a smaller portion to start with and then a second portion to maintain the optimal consistency.
Okay, thank you. I'm going to read a comment here from a speech pathologist on the call regarding IDSI and food texture. In addition to the key properties of particle size, hardness, and cohesiveness, I think I also make selections based on the amount of moisture in the food, and also taking into consideration saliva production in patients that might have xerostomia or dry mouth.
I think that's a really good observation. I think that the stickiness, the tests around stickiness will probably capture that variation in moisture that you're referring to, but the recognition that there may be some types of disorders where people have drier mouths will mean that the optimal stickiness or slipperiness of a food will be different for them than it is for people who have normal saliva. And indeed, there might be people with excessive saliva as well. So understanding how saliva comes into play is an important consideration.
Dr. Steele, when you mentioned that thickening liquid should be considered kind of as a last resort, what percentage of patients that you have seen have you made that recommendation to modify a diet, would you say?
That's a tough question. I would say that early on in my career, I made that recommendation very easily, and I've become less likely to make it these days. I think it's on the list of potential recommendations that can be discussed with a patient, but it should only be one of several. And so I would these days, first of all, in my assessment, I would want to include a variety of consistencies if I see a problem. So I would start with thin, and if I see penetration aspiration with thin, then I would want to explore the possible benefit of thickening. If I see a lot of residue with extremely thick or pudding thick consistencies, then I would be wanting to also go thinner and understand where the sweet spot might appear to be. And that would inform the discussion. But of course, I would also want to look at other factors. So it's hard to come up with a percentage. But I would say that it's very often on the menu of things that are being considered.
Thanks. We have a lot of questions that have come in, and I don't think we'll have a chance to get to all of them, but I think I want to end on this one, if that's okay, if we do one more with you here. There's a comment and a couple questions attached to it. So it says, I have often heard IDSI isn't a diet order, but that seems to be how it is being used. How do you address these perspectives? We seem very diet order driven at the moment. This could promote more entrenchment in that perspective. Thank you.
Yes, so historically, food trays or food and liquid for patients was ordered as a diet. And I think this, it usually did have these three components: the nutritional composition, the food texture, and the liquid. And it usually operated under that system where there was a list of allowed foods and excluded foods for the level. With ITSE, what we're trying to shift people towards is to think of a range of foods and liquids that can be safely and efficiently consumed. And so if you think of the pyramid picture on the framework, that range for a given patient will fall anywhere between the liquid consistency that you feel is least restrictive and appropriate, and the food consistency or food texture that is least restrictive and appropriate. So the logic is that the intervening levels are also likely to be okay. And so I think for me, this was a big paradigm shift when I first started to understand it. I actually think that before that, I imagined that when I made a recommendation for pureed food, that all of the food on the tray was pureed. But now if the recommendation is for minced and moist foods and slightly thick liquids, then according to the logic, there would be several other consistencies in between those two boundary conditions that would be suitable. And so much more variety becomes possible. It is difficult to change order entry systems, but this is coming. So ITSE has been working with the Nutrition Care Practice Guidelines for the American Academy of Nutrition and Dietetics, and also with the design of hospital computer systems for food ordering. And so it is coming, but it isn't fully implemented yet and will take some time. But I think also by focusing on this texture range concept, we also are clarifying that the role of the swallowing clinician here is to talk about consistency and not about the nutritional composition of the diet, and that this dissociates those two things hopefully more clearly.
Excellent, thank you. I appreciate that. We had several questions come in. If we didn't get a chance to answer your question, please feel free to email us. A lot of the questions too, that some more information can be found on the ITSE website, so itse.org, and we'll send a follow-up email with that information as well. And for now, Dr. Steele, I'm going to turn this back over to Ed, and thank you again for joining us. We really appreciate you volunteering your time.
My pleasure. Thank you for having me.
Catriona, before you leave us, I have two questions that are more geared to that 4% of people who are patients or caregivers.
Please.
Could you talk about how and why thickening liquids help the patient?
Sure. So I think that there's actually no rocket science here, and what I've learned over the years of studying this is that the issue is that thicker liquids flow more slowly. And because in swallowing, we need to close the entrance to the airway before the liquid arrives there, then because the liquid is moving more slowly, the patient has more time in which to achieve that closure. The other thing is, if you have residue in your throat already of a thin liquid, the next time you go to swallow, that liquid moves around very much more easily than a thicker liquid would. And so there's a risk of that material being knocked into the airway on later swallows. that risk is much lower with thicker consistency. So it's really about timing, and liquids that slosh around and move very fast are much harder to manage than the slower flowing liquids.
Thank you. That was the answer I was hoping to hear. The other one is, can you describe the difference between aspiration and penetration?
Yeah, sure. So the difference is really the depth to which material gets into, how far down it gets into your airway. And so the top level of the airway is the larynx, the voice box. And at the bottom of what we call the laryngeal vestibule, or the opening to the airway, are those vocal folds. And so material getting into that vestibule or that entryway is what we call penetration. So it's on its way, but it hasn't actually gone down through the vocal folds into the lower airway or the trachea. And then we also make a distinction about whether the material is then ejected back out into a safe location, usually by a coughing response. But penetration versus aspiration just refers to how deep it travels into the airway.
Terrific. Thank you for that. Thank you for exposing the other 50% of folks to ITSE. And we appreciate your time this evening.
Thanks for having me.
Yep. And with that, Elizabeth, could you put up the next closing slide?
Yes, I will do my best here.
Thank you, Catriona.
You're very welcome. Thank you for having me.
Thank you.
I just wanted to thank everyone for attending. Our next TAD talk is on November 28th on aspiration pneumonia. And if you had a question that was not answered, please email us at info@nofd.com. And within a day, we'll send out an email that will have a survey of tonight's discussion, and hopefully you'll provide us with feedback. And next, please. So once again, November 28th, how to manage aspiration pneumonia when the stakes are so high. So we look forward to having you join us again, and thank you. So I hope everyone has a good evening, and for those on the other side of the world, a good day, and thank you again for joining us. Good night.